Nearly 30,000 life-saving organ transplant procedures are performed annually in the US. Organ transplants are quite common around the world. And as we know, an organ transplantation is a life-saving procedure. But while organ transplantation gives patients another chance at an extended life, it comes with substantial risk. As dermatologists, we might be faced with patients who have cutaneous complications after a transplant. And thus, understanding how to manage these patients' condition is critical to providing an improved quality of life to them. To explore the topic of cutaneous manifestations for transplant patients, we have the honor of having an expert on this topic, Dr. Jose Manuel Mascaro from Barcelona. Dr. Jose Manuel Mascaro is a consultant physician of the dermatology department at the Clinical Hospital of Barcelona, as well as the head of professor of dermatology at Barcelona University. Dr. Mascaro is internationally known for his contributions of over 100 scientific papers and book chapters in well-known dermatologic publications. Most importantly, Dr. Mascaro is in charge of the dermatology inpatient unit at the Hospital Clinic de Barcelona, where he oversees the autoimmune skin consultations and cutaneous pathology of transplant patients, both solid organ and stem cell transplants. Dr. Mascaro, it is a real pleasure to welcome you today.
Thank you very much. The pleasure is for me.
Let's get started. How often should people see a dermatologist after an organ transplant or a stem cell transplant?
That depends on the patient. So, for example, if the patient doesn't have skin damage, sun damage, and it's a young patient, maybe they don't need to see a dermatologist for several years. But if it's a patient that's old, like a 50 to 16-year-old who has had a lot of sun damage and it's fair-skinned, then it's reasonable to see them between the first 6 to 12 months after organ transplantation. In the case of stem cell transplantation, it's different because although they have a risk for skin cancer, normally the most of our consultation are due to graft versus host disease. And then this is normally the consultation is made by the hematologist if there's any manifestation.
What is the most common type of skin cancer after transplant surgery?
Normally most frequent is squamous cell carcinoma, and also the precursor, which are actinic keratosis. Although that also depends also in the area. For example, in the south of Europe, in Spain, we see also a lot of BCC, a lot of basal cell carcinoma, and it depends. So, for example, people from fair-skinned and northern European ascent have more squamous cell carcinoma. People who are more Mediterranean, we see more basal cell carcinoma.
It's really interesting because in the general population that doesn't have organ transplants, BCCs are more common than SCCs. How come in the transplant population this seems to be reversed?
I mean, we don't really know the reason because that depends also on the population, but it's an observation that the ratio is inverted. So normally in the general population, based on CC, we see one SCC for every 3 or 4 BCC, and in patients with solid organ transplantation, the ratio is inverted. But the real reason is not really known.
Okay. And
so there are
what
several
is the
factors. Mm-hmm.
There's still, of course, it's science, so there's still a lot to be learned. What is the likelihood or how much greater is the risk of developing a skin cancer after a transplant?
Can be more than 100 times the times that from a regular person.
Wow. And is there a typical duration, like if you see, is it typically like a year later, or is it several years later that after their transplant that you likely see this skin cancer come about?
Normally, the risk is related to also to immunosuppression. So normally, the highest risk is after 10 years of transplantation. But also, if the patient has a lot of skin damage, and it's an older patient, then we can see skin cancer before that time.
So we're talking risk factors here, and you mentioned duration of immunosuppression. What other risk factors are there for a patient for developing skin cancer after their transplant?
So the most important is, as I told you before, the age of the patient. So older patients have higher risk. Sex is also important, so it's higher. The risk is higher in male patients. Also, the sun damage from the patient is important. So if a patient has a lot of sun exposure before transplantation, that makes it higher. Then also the duration of immunosuppression and also the amount of immunosuppression. For example, it has been seen that patients who have take more immunosuppressants or have higher doses of immunosuppressants have a higher risk. And this is also particularly seen in patients who have a thoracic transplant like heart or lung, and it's lower in patients who have an abdominal transplant, like, for example, renal or hepatic. And normally patients who have a liver transplant, they get less immunosuppression. The risk is a little bit lower.
Is there any correlation with the type of transplant that the recipient receives that correlates with the type of skin eruption that you might see?
Sorry, I don't understand your question.
So is it typical, like, for instance, if someone receives a kidney transplant, is it more common that someone who receives a kidney transplant get SCCs versus a patient who received a liver transplant or a stem cell transplant?
For example, in the renal transplants are the most common patients. So that's what we see every day in the clinics. Then these are the type of patient where we see more cancer. And I think in general, we see more risk than in liver transplant, but that depends also on the patient. So we can have patients with liver transplantation who get a lot of squamous cysts, so we cannot really differentiate. In patients with stem cell transplantation, normally we see a risk of cancer after some years after transplantation, in particular in patients who have had chronic graft-versus-host disease, and in particular also patients who are fair-skinned and had a lot of sun exposure. But normally these patients with organ transplantation, when we see them, they are not anymore with immunosuppressants, because normally they can be taken off, but the risk is it can be similar to a patient with renal transplantation.
And do you understand why AKs, actinic keratoses, seem to progress much faster in the transplant population versus the general population?
I mean, I think it's everything is related to the immune system. For example, in non-immune depressed persons, a lot of these precursors lesions can be managed by the immune system. So the immune system gets rid of a lot of malignant cells in our bodies, not only in the skin, in other organs. But in these patients with this who have an immune system that is not working well due to immunosuppression, then the risk of progression of any cancer is higher, and any precursor will go much quicker.
Right. And what, I was a cutaneous oncology fellow, so I would see patients come in after their transplant and their legs would be covered in SCCs, and we would often do something called chemo wraps. What are your treatment options that you usually go to for patients with multiple lesions that are more than just excising one or two lesions because there's too many that you can't excise them all?
Okay, for patients who have multiple, we don't use these chemo wraps. We use topical therapies like topical fluorouracil. We use sometimes photodynamic therapy, sometimes combined with laser. And if the patient develops a lot of lesions, sometimes we use systemic treatments like um, acitretin or even capecitabine. Oral capecitabine can be used, although it's not. We have to use it off label because it's not approved for that, but we can ask for that.
Okay. So we mentioned a lot about basal cell carcinomas and squamous cell carcinomas. How about melanoma? Is it common that you see an uptick of melanoma in transplant patients? As you said, of course, when someone is immunosuppressed, you usually can get progression of other cancers much faster. But do you see a much greater risk for developing melanoma? And what is the survival like for these patients?
Yeah, so the risk of melanoma is also higher in these patients, although we don't see a lot of it. It's not like for non-melanoma skin cancer, which is more frequent. And most of the patients that we see, they have a localized melanoma because normally we check them. So as we check them, we can detect the melanoma in early stages. But when these patients develop melanomas, if they progress, then due to the immunosuppression, they have worse prognosis. One of the problems we can have with these patients is if a patient with an organ transplant patient develops melanoma, and you need to go further than surgery, and you need, for example, immunotherapy. There's a complete contraindication for these patients because the immunotherapy can make the transplanted organ to be rejected, and that's in the case of a renal transplant, you always have hemodialysis, but in other transplants, you don't have options in this patient. So that's a problem we have been faced in some patients who had advanced disease, that it can be a real problem.
And are there certain medications, of course, the transplant can make you immunosuppressed, but so can the medications that the recipients are given after. So are there certain medications or drugs that we find are making people more prone to developing skin cancer versus other immunosuppressants?
Yes. For example, some immunosuppressants are worse than the others. So in particular, cyclosporine and azathioprine are the highest risk. So in particular, azathioprine has a very high risk of developing skin cancer, and now it's not used as a regular medication for transplant organ, but some patients have been taking them for 30 to 40 years, and then it's difficult for the transplant team to remove this medication. But sometimes if the patient is developing a lot of skin cancer, we talk to them and try them to have to change this medication for another one. And this is also the case with cyclosporine, but it has a less risk than azathioprine. And then the other type of medication is voriconazole. So voriconazole is an antifungal drug that is used in immunosuppressed patients to treat deep fungal infections. But the problem with this drug is that the patients who are taking it for a long time, they can develop a phototoxicity and also a high risk of carcinogenesis. And this has been shown in different studies.
Wow. After a patient has been referred to you from their transplant doctor, how do you typically educate them after they have received their transplant?
Okay, so the first thing I have to advise them that the risk factor apart from the immunosuppression is sun exposure. So I have to try them to. I have to tell them that they have to avoid sun tanning because a lot of people are addicted to sun. Of course, for them it's good to do sports and do outdoor activities, but they have always to use physical protection. So I tell them always that the physical protection, like hats and shirts, are the best protection. Even if in the other areas they have to use high SPF, and also I am tell them that they have to do regular checkups. So normally with all these patients we do checkups every 6 to 12 months. If the patient is developing regular skin cancer, we do it more frequently. And then also the other thing we try to teach them that if they have any suspicious lesion, in particular painful lesion. So pain is it's a marker of cutaneous squamous cell carcinoma. Then they should come and ask for an appointment before the next visit they have with us.
Do you recommend doing a pre-screening? I'm sure you collaborate often with the transplant doctors. Do you recommend that the patient comes for a pre-screening of their skin just to make sure that they don't have any skin cancers before starting the transplant?
We don't recommend it regularly because there are so many patients. So there are a lot of people in the waiting list, and we cannot, we don't have, there are not enough physicians to check them. So normally what we tell to the transplant team, if the patient has a history of skin cancer, or they believe they can have some skin cancer, they should send it to us, but they don't send us all the patients because that's would be a huge amount of work for us.
Not enough resources.
No, we don't have enough people to see them.
I'll come to Spain and help you out.
No, of course, we have the system is very different in Spain because we have a public system. So everyone has a public insurance that is covered, and they can see the dermatologist. So they don't have to pay for. They have only to pay for the SPF, the sun protectors, but not for the medication and for the visits or the procedures. So that's different in other countries. It's the patients will have a different access to dermatologists.
Of course. So we've spoken about skin cancer here, and I understand that there are other types of skin eruptions that someone might develop outside of skin cancer after having a transplant. Can you share what those might be and how you go about dealing with them?
Okay, so we can have two type of different eruptions. We can have drug eruptions, which are not so common, but we can see them. So, for example, in particular with sirolimus and everolimus, which are mTOR inhibitors, it's pretty frequent to see some acneiform rashes. So the patient, in particular, if the patient had a previous history of acne, they can develop acne in the face or in the back, which can be sometimes difficult to deal with. And then we can have also other type of drug eruptions. And then the other type of eruption we see are cutaneous infections, which are more frequent. So we see frequently different types of tinea, pityriasis versicolor, tinea pedis. Also, we can see viral infection, in particular herpes or herpes zoster, which can sometimes be important, and sometimes they would need even intravenous medications. And then we have a lot of problem with warts. So warts are terribly common with these patients, and sometimes we have very severe cases of warts that are difficult to deal because of the immunosuppression. Even if it's not normally, it's not nothing serious, but it can be important for the patient.
It's aesthetic also, and it can also be quite a nuisance. So I understand that.
Mm-hmm.
Is there a timeline for these cutaneous eruptions to occur post-transplant? So like in the first month post-transplant, do you see more like surgical complications? And then at what month do you see more fungal infections? Just a general timeline. I know obviously every patient is unique and things can change and differ.
Oh, for example, drug eruptions, we will see them in the first months because it's the time when they're giving more drugs. And then the viral infections like herpes or herpes zoster, we see them at the first months because they have more immunosuppression. And then the other type of like tinea or warts, then we can see them all over time. They are more typical in long persons who have been transplanted for years.
Okay, and do you ever see rare or opportunistic infections such as cutaneous nocardiosis, Bartonella, or atypical mycobacterium?
Sometimes we see those, but this is not really frequent. So we can have two different settings. Sometimes the patient is admitted to the hospital with a life-threatening infection that comes out to be an opportunistic fungus, and then sometimes we are called on consultation if there are cutaneous lesion we can help with cutaneous biopsies, but can happen, but it's rare. And sometimes we see some patients who are feeling well and they develop some bumps on their skin, and then we do the biopsy, and then we find out this was a localized deep fungal infection. But normally they are sometimes even they develop. We've seen patients that develop like a cyst. It looks like a cutaneous cyst, and later on when we do the biopsy, we find on the biopsy there's a fungal infection by any opportunistic, but normally they're very localized. And then we discuss them after that when we've done the diagnosis with infectious department, and sometimes they want to do some infection, to give them some drugs. But I think most of these cases, they are so localized that surgery is enough to cure these lesions.
Okay. And what is your threshold for performing a biopsy? Because as we all know, drug eruptions can have various morphologies and have many different clinical presentations. So do you find that you are like waiting and say this is likely a drug eruption, like let's wait and see, or do you kind of quickly say this patient's immunosuppressed, we don't want to wait too long, let's do a biopsy?
So my threshold normally is if I see an inflammatory eruption, for example, in an organ transplant or in a stem cell transplantation, if I think that the eruption is going to go away with a topical steroid, then maybe I don't do a biopsy. So I first try with a antihistamine and give them a topical steroid, and then see them in a few days, in a week or 2 weeks. So if the eruption goes away with the topical therapy, sometimes we don't need to biopsy. We know it was something inflammatory, but it's gone away. So if the eruption, if it looks like this eruption is going to get to need something else than a topical steroid, if you think maybe I would need something systemic, or I don't know if this is going to be graft versus host or it's going to be a drug eruption, and this is going to change the treatment, then I think we'll go for biopsy. But we don't. I mean, when it's a mild rash, we usually really don't biopsy.
Okay. And what are the variety of superficial fungal infections that you might see on a transplant patient?
Normally, the what we see is tinea, like in the general population. We see tinea pedis, we see tinea young, nail tinea, nail fungus, and then sometimes we see pityriasis versicolor.
Okay. And do you usually is it difficult to treat the transplant patient when they have, since they're transplant patients and they're immunosuppressed, is it difficult to get them effectively treated with the antifungal medications?
The main problem we have with this patient is that normally they respond well to topical therapy. The main problem we have is with systemic drugs. So most systemic antifungals, in particular the azoles, they interact with the immunosuppressant. So if you want to give some systemic therapy for a nail infection, the transplant team normally don't agree. They say don't give them any drug because this can modify the immunosuppression, and this sometimes you can have a risk that the patient has a rejection of the organ.
Of course,
so that's a problem.
Err on the side of caution.
Yeah.
So you mentioned that with a transplant patient, a human papillomavirus the occurrence can increase as well. Mm-hmm. Do you see that with transplant patients that it's typically more likely, or the risk increases for the HPV turning into a squamous cell carcinoma, just similarly to how the actinic keratoses in transplant patients turn into SCCs?
Okay, so I don't have this impression in the skin. So when we have patients who have warts, normally we don't see these warts becoming squamous cell carcinoma. The problem is mainly with genital. disease. So if we have patients, so in particular, when we have patients with a genital disease, both men and women, then we have to, normally we send them to the gynecologist. Also, also have a program in our department together with infectious disease physician to check for the anal, to have a precancerous lesion in the anal area. So in this program, they both see patients with HIV who develop precancerous lesions in this area, but also other type of immunosuppressed patient, and these are is also the case of organ transplant. So, but normally I don't take care of these patients. So there's one of my colleagues who takes care of these patients. So if we see anything in the genitalia, then we send both to the gynecologist and the anal screening clinic that we have.
Mm-hmm. Makes sense. So in the future, do you foresee, there's a big push now to do targeted therapy, and it's going to be in the next couple of years. I think a lot of the chemotherapies and a lot of the drugs that come out will be more targeted. Do you think that will decrease the risk of skin eruptions and development of skin cancers?
Not right now. So I think that's maybe in the future, but not right now. I don't see how this is going to modify the risk of skin cancer in this population. Are you thinking in any particular drug?
No, I'm just thinking very broadly that if we target cancer more specifically, then the idea and the hope is that we would decrease the amount of immunosuppression in the rest of the body. And by doing that, I would hope that we would have less skin cancers or skin eruptions.
Yeah, right now, if we see a patient who has a lot of skin cancer, what we have right now is acitretin, which is non-specific, but it will help to lower the risk of squamous cell carcinoma and also actinic keratosis in these patients. And then also there's nicotinamide, but nicotinamide has been used in some studies with non-immunosuppressed patients. So the evidence in patients with organ transplant is less strong, but it probably can be used in the future. But these are not non-specific; they are not targeted therapies. But maybe in the future we have some type of drug that will help us to remove all the skin cancer. What we have been using in a few patients is capecitabine, which is a prodrug that becomes 5-FU in the body, and that also helps us in some of patients who have a lot of risk, but it's also non-specific therapy.
I hope you enjoyed this episode of the Derm Club podcast. If you found the discussion today to be valuable, please subscribe and share. I look forward to seeing you in the next episode as we continue to delve into dermatology and skincare with the world experts.